All right, so we'll talk about the investigational FORMA early feasibility study during this talk. And I'll start with a case, similar to some of the other cases you've seen. This is a 69-year-old woman with class 3 dyspnea, abdominal fullness, lower extremity edema managed with high-dose diuretics, and previous bypass grafting surgery, type 1 diabetes, stage 3 chronic kidney disease, and also paroxysmal atrial fibrillation. This is her echocardiogram. You can see on the top left the annular dilatation in the RV inflow view, and then the significant color Doppler jet, as Paul would say, a lot of TR, and then the continuous wave Doppler showing a dense dagger-shaped signal, and then your flow reversals present in the hepatic veins during systole. So all findings of severe TR. And the 3D echo helps us understand the mechanism a little bit more, and that you see a large central jet of tricuspid regurgitation. And really the mechanism here was annular dilatation, what we've been talking about. And this seems to be the most common type of mechanism that I see in my patients is patients with chronic AFib and progressive atrial enlargement that then results in annular dilatation and TR. So the FORMA repair system is probably the most simple technique of all the ones that you've heard about today. It really is kind of the opposite of the annular reduction. So it's a spacer that's positioned in the regurgitant orifice, and it creates a platform for native leaflet coaptation, and it's positioned over a rail that is anchored in the interventricular groove of the right ventricle, and then also in the prepectoral fascia, and it's delivered via a subclavian approach. It's available in 3 sizes, and really only the 12 and 15 millimeters have been used to a significant degree, and only a couple of cases using the 18 millimeter device at this point. As part of the evaluation, gated cardiac CTA is essential, and it helps define the subclavian anatomy and ensure that there's adequate size for the delivery of the sheath and the device. And then also to look at the anatomy of the RV, look at the moderator band, if you've heard talking about the importance of existing pacemaker leads, and then identifying a coaxial site for that anchor deployment. And this is the RV-gram that we did during the procedure, kind of showing the beautiful anatomy of this massively enlarged RV and atrium. And we use this RV-gram to identify the site of the anchor. And this is based on a projection that was predicted by the CT. So the FORMA procedure involves a steerable catheter that's delivered via subclavian approach, left subclavian approach, and it's balloon tipped, and we navigate it into the RV, and this is what it looks like on fluoroscopy. And then the anchor is positioned very carefully. This is the most critical part of the procedure. We use transgastric TEE guidance to confirm that that anchor is in the place where we want it to be, and then also cine angiography to confirm that as well. And once that anchor is in place, then we can track the spacer over the rail and then position that and fine-tune the positioning based on tension on the rail and positioning of the spacer using TEE guidance. So in this patient that we were talking about, this is her baseline TR before the FORMA device, and then immediately after you can see that spacer sitting there, and you see some reduction in the color jet. But of course this is very difficult to quantitate, as Becky knows very well as being the core lab for this study. But you can see, she'll be happy to see that we have 3D vena contractus here on this slide, and you can see that that reduced significantly, the 3D vena contracta area. And then the reversal TVIs in the hepatic veins also reduced significantly acutely. So it's important to collect this detailed echo data in these patients. And you can see that starting out, this patient really was in that torrential group, or massive to torrential group. You can see a reduction in the right atrial pressure, similar to what Paul just showed you. You see kind of a ventricularized waveform at baseline, and then immediately after the spacer is put in, you see an acute reduction in the RA pressure. And what's been encouraging is that these patients seem to have a progressive improvement in follow-up. We can see that the 6-minute walk distance improved at 1 month and 6 months sequentially in this particular patient. NT-proBNP reduced, and the bilirubin also reduced, so the hepatic congestion is going down in these patients. And you can see that Potentially even the RV size has decreased at 6 months, although this is probably a limited evaluation with echo, as we've heard, and perhaps MRI could give us more definitive data about that. You can see the 6-month changes in EROA, about almost 50% reduction in the EROA in this patient at 6 months. And the systolic flow reversals in the hepatic veins have pretty much gone away at 6 months. So this is excellent progress in this one patient. But what about the early feasibility trial? This was 30 patients with secondary, or also called isolated TR, due to annular dilatation, excluding patients with primary TR, pulmonary hypertension, advanced kidney disease, or inadequate subclavian anatomy. And there were 5 sites that were involved in the study, and Sushil Kadali presented the 30-day results at TCT. The patients were elderly and predominantly female. You can see 67% women, high STS score, and also high prevalence of atrial fibrillation and right heart failure. And just to show what Becky was talking about, this is the spectrum of EROA in this population, and about 2/3 of these patients had torrential TR. So this is really the most extreme state of disease, and I think the Forma is probably one of the more suited devices for this because of this simple nature of it and just the mechanism. So the study flow, 30 patients initially included. One procedure was aborted because of inadequate vein anatomy. There were 2 episodes of RV perforation during the procedure, one of which resulted in death, one of which converted to surgery, and that patient survived and did well. And then 27 patients had the device successfully implanted. There was 1 episode of device migration, which required explantation. That patient subsequently died after 30 days, and then an explant due to infection as well. Interestingly, there were 2 anchor dislodgements, and the spacer remained in the desired position, and those patients have been followed serially. So there were 25 patients available for 30-day echo follow-up. These are the endpoints. Death occurred in 7% of patients at 30 days, and major bleeding occurred in 14%. And you can see cardiac surgery was required in 3 patients, so 10% of the patients in this initial experience with the device. But it's important to note that 69% of patients had none of these above events, and this is the first time this device was ever implanted in the United States. So you can see the EROA reduced significantly in the majority of patients, about 40 to 50% reduction at 30 days. And the NYHA class also improved, similar to what you've seen in the other device experiences. So the majority of patients, 70%, were NYHA class 1 or 2 at 30 days. And this was reflected by the 6-minute walk distance, an improvement of about 40 meters at 30 days, and also the Kansas City Cardiomyopathy Questionnaire. And these results mirror what we've seen in the compassionate use experience with the Forma device, which is in 18 patients, international experience. The results with this were actually, there were no episodes of mortality at 30 days or 1 year, even though this was the first time the device had ever been placed, and really a low rate of adverse events in general, and a similar improvement in 6-minute walk distance at 30 days and 1 year, and Kansas City Cardiomyopathy Quality of Life. But really detailed echo data and other markers were not available in this population. We're really interested in those other endpoints, as Becky has already talked about. So in summary, in a patient cohort with torrential TR and multiple comorbidities, the Forma repair system was feasible, and the next generation is about to be rolled out later on this year through the early feasibility study, and that'll have improvements in device delivery and safety to help reduce the risk of dislodgement and perforation. And despite torrential TR in most patients, there was significant reduction in EROA, especially in the people with more severe disease, and also improvements in quality of life and 6-minute walk distance. Thanks for your attention.